Okay, when risk factors are present in young women, they should be aggressively modified and not ignored under the mistaken assumption that young women are protected. So, pregnancy is the first stress test for a woman. The incidence of cardiovascular events in the next 19 years were more in people with migraine. Young women are more likely to develop myocardial ischemia with mental stress than men or older subjects. A study was initiated to differentiate between the risk factors between men and women. It was found that 4 risk factors were more prevalent and more associated with MIs in women as compared to men, and these were hypertension, diabetes, lack of physical activity, and alcohol intake. And what about the differences between the young and the old? Elderly persons, risk factors were more strongly associated with acute MI in the younger people as compared to the older persons. ApoB levels, current smoking, hypertension, and diabetes were more strongly associated with MI in younger compared to older women. And ApoB-A ratios, current and former smoking, hypertension, and abdominal obesity, but not diabetes, were more strongly associated with MI in younger compared to older men. And the protective effects of physical activity and regular alcohol consumption on MI were stronger among older compared to younger men. Now, what about differences between young men and young women? Well, there was a significant difference in the rates of myocardial infarction. Young women had lesser rates of myocardial infarction than young men. But the major difference, the 80% of this difference was due to difference in distribution of risk factors. And the difference vanished when the rates were adjusted with the risk factors. That means if women did not have risk factors, the traditional risk factors, the rates of MI were less. But if they had risk factors, their MI rates were as high as men. And these risk factors were diabetes, hypertension, smoking, and ApoB-A1 ratios. So, concluding the age and sex correlation in the interheart, women experience MI almost 9 years later than men. Earlier age of acute MI in men largely was explained by higher levels of risk factors, mainly smoking and lipids. Lower MI burden in young women was explained by lower prevalence of risk factor burden. But when young women had risk factors like hypertension, diabetes, ApoB, and smoking, their incidence of MI was the same as men. So the moral of the story was that when risk factors are present in young women, they should be aggressively modified and not ignored under the mistaken assumption that young women are protected. Now, what about sex-related or biological risk factors? These are biological risk factors, pregnancy-related and other biological risk factors. This was a large systematic review and meta-analysis of 83 studies, including over 28 million women, correlating pregnancy complications with future risk of cardiovascular disease. And it was found that preeclampsia, gestational hypertension, placental abruption, preterm birth, gestational diabetes mellitus, and stillbirth all had increased risk of future cardiovascular events from 1.5 to 2.7 times. So pregnancy is the first stress test for a woman. Those who fail the test, means those who have preeclampsia and other placental problems, are at increased risk of long-term complications, chronic hypertension, diabetes, ischemic heart disease, kidney disease, venous thromboembolism, hypothyroidism, and even decreased memory. Preeclampsia has increased by 25% over the past 2 decades in US and almost 10% of pregnancies. And with CV disease, preeclampsia shares many risk factors like endothelial dysfunction, obesity, hyperglycemia, insulin resistance, diabetes, hypertension, and the peculiar dyslipidemia of high triglycerides and small dense LDL proteins, lipoproteins. The risk is highest among women who develop both maternal and fetal manifestations of abnormal placentation, especially in preterm delivery. And also important thing is that the risk is high, of cardiovascular risk and hypertension, even in the offsprings who come out of these pregnancies. So if pregnancy is a window to subsequent cardiovascular health, the postpartum period is a window of opportunity. Hence, a checklist of practices and interventions within the first year postpartum for such women has been developed. Counseling, like giving counseling about long-term risk and need for ongoing evaluation and screening, monitoring blood pressure, doing a glucose tolerance test in women with history of gestational diabetes, assessing lipid profiles, promoting healthy lifestyle, and a multidisciplinary approach to the screening and surveillance and counseling program for women with pregnancy complications. Now, what are the other sex-related biological risk factors? Polycystic ovary syndrome associated with risk factors. Premature, that means less than 40 years or early, below 44 years, menopause, poses a risk which is 1.5 to 1.3 times. Oral contraceptives, about 0.9 to 2.3 fold risk. Radiotherapy for breast cancer, breast arterial calcification, migraine, and the hormonal changes during menstruation all pose some risk, which we shall see. Radiotherapy for breast cancer has a direct linear relationship to the dose of the radiation. That means about there is a increase of cardiovascular risk of 7.5% per gray of absorbed radiation, and this risk extend to from the time of radiation to more than 20 years. Then breast arterial calcification has been found to correlate with coronary artery calcification and with cardiovascular events. Of course, these are from retrospective studies, and the exact quantification to give you cutoff limits are not worked out, but one can make out that some women have mild, moderate, or even severe breast arterial calcification. And both the breast arterial calcification and the parenchymal microcalcification pose increased risk to women, one of cardiovascular disease and the other of breast cancer. And this is a unifying concept which tells us that preventive strategies can work for both lifestyle changes, medical therapies, follow-ups, etc. So both cardiovascular disease and breast cancer can be reduced by monitoring such patients who have calcifications of these two kinds and targeting treatment for them. What about migraine and young women? This was a Danish population-based matched cohort study in which 50,000 people with migraine were matched with a cohort of 500,000 people and followed up for 19 years. Median age was 35 and majority of them were women. So you can say there was a study of young women. And what was found? The incidence of cardiovascular events in the next 19 years were more in people with migraine. What was more was myocardial infarction, stroke, both ischemic and hemorrhagic, and atrial fibrillation, VTE. Now, over a period of 19 years, myocardial infarction was 1.5 times, ischemic stroke was 2.2 times, hemorrhagic stroke was 1.9 times, VTE was 1.5, and atrial fibrillation was 1.2. Highest relative risk was found in the first year after migraine. Higher risk in women as compared to men, and in patients who had aura as compared to patients who did not have aura. There was no meaningful association of migraine with peripheral artery disease and heart failure. So what is the message from this? Will reducing the frequency or severity of migraine reduce the risk for cardiovascular disease? What is the role of prophylactic use of aspirin? Well, we don't know the answer to these two questions. But one thing we know is to be more aggressive with lowering other risk factors in women who have migraine. And then, of course, the menstrual cycle, the hormonal changes, it has been found that the time to ST depression for each of the 4 phases of menstrual cycle is different. In the early luteal phase, just after the menstrual period, is the time when the maximum incidence of ischemia can occur. So this is the change, the people with coronary artery disease and the menstrual cycle. Now what about gender-related risk factors? Gender is different from sex-related in the sense gender is related to socio-economic, socio-cultural, socio-demographic, and psychosocial factors which are different from the sex-related factors which are biological. For example, being unmarried and unemployed, having financial stress, more life adversities are more common in women. Lower income and education associated with excess risk. Depression has a higher prevalence in women and a greater attributable risk. Physical inactivity. Young women are more likely to develop myocardial ischemia with mental stress than men or older subjects. Then young women have other pre-myocardial infarction factors which are more common, like prior cardiovascular disease like heart failure, peripheral artery disease and stroke, higher prevalence of comorbidities like COPD, renal failure, autoimmune disorders, cancer and psychiatric disorders. Then there is a coronary artery disease with almost no risk factors except maybe hypertension associated. And this is pregnancy associated spontaneous coronary artery dissection. It frequently occurs in the first month after delivery and more common in multiparous women. Still, the hemodynamic factors, the exact etiological factors, hormonal factors which cause this are not worked out. But this can be a drastic emergency because many patients have dissections of the left main or multivessel arteries. So what is the impact of all this on young women? Well, as you can see, in this young population, the incidence of myocardial infarction hospitalization is decreasing in men, whereas in women over the period of 95 to 2013, it has been slowly going up. So infarction in young women has not gone down the way it is going down in all other age groups and sexes. The mortality rates also, if you compare men and women above the age of 54, and if you compare with the men and women below age of 54, you can see that everywhere the incidence of mortality is going down, but not in young women where it has plateaued. So concluding, the later occurrence of MI in women as compared to men is mainly due to lesser prevalence of traditional risk factors in young women as compared to young men. But when risk factors are present in young women like diabetes, hypertension, smoking and ApoB-A1 ratios, their chances of MI become as high as men. Women with AMI, especially young women, have more risk factors, more comorbidities and poorer health status than men of similar age. So sex hormones are not always protective. Hence, risk factors in young women should be aggressively pursued and treated and not neglected in the belief that they are a protected species. Pregnancy complications are a window to future cardiovascular risk, and puerperium is a window of preventive opportunity. Psychosocial stress is an important risk factor in women and needs understanding how social and clinical factors interact to produce disease and needs a interdisciplinary intervention. So the heart of a woman is not different, but is special and requires special care. I'll conclude with a beautiful quote, a woman's heart. The trouble with a woman's heart is that it knows nothing of boundaries. It is the wild and unconditional thirst of the soul, like the small fire which trembles before the wind, only to collect itself and offer itself once more. Thank you.
Insights from the world's best medical minds. You are watching therightdoctors.com.